Well, welcome everyone to exam number 3 review. My name is Professor Irene Dunham, and I will be your host. And we're going to go over 4 chapters. Chapter 10, 12, 13, and 14. These will be the chapters that your unit exam number 3 will be over. Okay. So by now I know you all have read the chapters, and so this should be a pretty good review. And just pay attention, write things down as you go along. I'm going to go ahead and share my screen, so it just keeps me on track with everything. And so I'm going to share. And so here we go. So again, these are the chapters that will be covered on your exam. So we talk about chapter 10, we talk about nursing care of women with complications after birth. So that means that they've given birth, and now these are some of the complications. And the big one is hemorrhage. Okay, so we classify them in 2 different ways. One is early hemorrhage that occurs within 24 hours postpartumly, or late hemorrhage. So it's after 24 hours and between 24 hours and 6 weeks, they go home. And that could be, they could have a late hemorrhage. And so this is how we classify. Now, I want you to take notice to shock, hypovolemic shock, which means low blood volume. So when you deliver a baby, there's a lot of blood that is expelled. There's a lot. And because don't forget, during pregnancy, blood volume increased from 45 to 50%. That's a lot of increase in circulating blood. So now when she delivers, she's going to be getting rid of a lot. And the uterus is very vascular. The whole process is very vascular. So we always want to make sure that we are on track. We're looking, we're assessing, we're clinically thinking hypovolemic shock. Write that down. And the main symptoms, when I see a patient go into shock, I think of tachycardia. That's because, remember, after delivery, it's very common for the woman to have bradycardia. So if my patient now delivered and she's tachycardia, that is a classical sign. And I would know that, okay? Tachycardia. At the same time, the increase of heart rate, her blood pressure is what? Is dropping because she's got low blood volume. She could show pale, cold, clammy skin. Sometimes they get kind of confused because even they get mental status changes and they have decreased urinary output. Remember, any patient that is in hypovolemic shock, the heart is going to demand more blood. So then blood that's supposed to go to like the kidneys would be decreased. Therefore, she had decreased urinary output. Okay. So again, remember hypovolemic shock. The first sign I would see would be tachycardia. Okay. So if I ask you a question, the first sign of hypovolemic shock is most often what? Is tachycardia. Good. All right. Now, another important characteristic is uterine atony, A-T-O-N-Y. I say it atony. That's how you can remember it. It's a uterus without tone. Okay, so what are you going to feel? It's difficult to feel the uterus because why? It's soft, it's boggy. So when you do your frontal massage, you're going down and checking the fundus, it's soft. You got to go way down. And where is this thing? I know it's there, and you have to go way down because it is soft. It's difficult to find. Now, the fundal height is usually above the umbilicus. So remember, after delivery, where should the fundus be?
Midline.
At the level of the umbilicus, right there, midline and in midline. So at the level of her belly button, umbilicus, midline. That's where it should be after delivery. And because the uterus is without tone, she has a lot more lochia. Lochia is the vaginal bleeding, is her discharge. And it could have large clots because the uterus, again, is not contracting. So now you have this boggy uterus bleeding. I hope you get the picture. And then she may not even have, she may be having a soft uterus, a lot of bleeding, but when you get up to go to the bathroom, you may not realize how much blood is being lost. So you have to be careful when you get your patient up out of bed after delivery, because she could get really hypotensive on you, and because she's losing a lot of blood. Okay. Remember, collection of blood in the uterus further interferes with contractions. Okay, so we have all this blood inside the uterus. It's not going to contract like it should, okay? So you get this uterus without tone. Now, what medication could I give this patient for a uterus without tone? Well, you would write this down, everyone. You would give, for urine tony, you give Methergine. Methergine. Now, Methergine works really well. It's very strong. So it does increase the patient's heart rate. It increases blood pressure. So you can be careful with this drug when you give it. Usually, it's no problem because she's usually hypotensive at this time. So Methergine is the drug to give. Write that down. And when I say write it down, what do I mean? I mean write it down, correct? So here's the question. Yes, thank you. Which medication will the nurse anticipate prescribing to control postpartum uterine atony?
Methergine.
Methergine, absolutely. Okay. See how important that question is? Okay. All righty. Another brain teaser. The nurse assesses a postpartum client and she notes uterine atony. Which action should the nurse perform first?
Massage the fundus.
Absolutely. Massage the fundus. You're right on track. Good deal. Love it. Okay, let's go on. So let's talk about a hematoma of the reproductive tract. So again, a hematoma, we know that is a collection of blood, and it's within the tissue, in the vulva usually. And I'm going to tell you, is very painful. And it's so painful that like analgesics such as Percocet, we give postpartum a lot, it doesn't even touch it. So again, it's a collection of blood in the vulva. Write that down. Hematoma is a collection of blood in the vulva. Now it can be in the pelvis, it can even be in the rectum, but what I've seen is these huge bulging bluish or purple mass right in the vulva. Again, it is unrelenting pain. It's very painful. And you know, when we talk about having a hard delivery, maybe she experienced some birth trauma, you know, inside the vagina as the baby's coming down, maybe they had to use forceps, could have been a big baby. And so it could have caused that perinatal tissue, which is very fragile. It really is. It's soft. It has a lot of blood vessels in it, that it could very easily get damaged and cause that hematoma. Okay. So if I was to ask you, what is the nursing action that's appropriate in the care of a postpartum patient to prevent fundal displacement? What would you do? So what's the question asking? Is asking, what are you going to do for to prevent fundal displacement?
So have her empty her bladder.
Exactly. Empty the bladder. Write that down. Empty the bladder. Absolutely. Good. So we're going to talk now with a woman with subinvolution, which is what we know. Involution is the return of the uterus to its pre-pregnancy state. Okay, it goes back down to being normal again. When you have subinvolution, that means there is a delay in that going down. So it could be that she's not feeling well. Maybe she has really a persistent red lochia. She could have a foul-smelling vaginal discharge. She could have an infection. Sure, infection. Infection causes fever and causes pain. So what are you going to do? Well, you give some comfort measures. And we may have to, if there's some retained placenta fragments, we'll have to go take her back and maybe do a surgical intervention. So this is kind of patient I'd be like you wouldn't give fluids to be NPO because you're thinking we got to clean out this uterus to get it to contract more. Okay. Let's go on to talk about some DVTs. Now, take note to this, DVTs. It happens postpartumly. It's a thrombus that could be in the vein, and it's like it's a blood clot, right? And what happens is that it forms like in the leg, and it gets the stasis during pregnancy. It's not moving. And what happens, you have more fibrinogen levels that are increased, especially during pregnancy, they are increased. So postpartumly, she is at high risk for developing what we call a deep vein thrombosis, which is a DVT. Now, those DVTs, they can break loose down in the leg because they get kind of stuck in one of the valves of the like a flap of one of the veins. It stays there. It causes swelling. It causes the patient pain. She can have some redness, and they usually feel this and they'll call the nurse and they'll say, "Oh, nurse, my leg is really hurting me." And the nurse says, "Okay, let me look." You assess that. You say, "Well, let me call the doctor," because you're thinking DVT and you don't want that to break loose, which it can happen, and it would travel right up into the pulmonary artery, and then she could have what we call a pulmonary emboli. So we want to call the doctor. We'll probably get an order for a venous Doppler study, and therefore, we're on it. And they probably would start her on some anticoagulant therapy. All right. So some classic signs of DVT include muscle pain, remember it's a positive Homan sign, and swelling of the affected limb. Is that true or false? That's true. When you got a positive Homan sign, you got muscle pain, you got swelling of the limb. Remember I told you in the calf, those are classical signs of a DVT. And I'll give you a heads up too. They're for all patients. So if you're on the med-surg floor and your patient starts to have difficulty breathing and has pain, you better look it up. Okay, so what can the nurse perform to prevent a thrombus from forming? What do we do? What do we encourage the patient to do?
Ambulate.
Ambulate, absolutely. Ambulate. Get them out of bed. And we do that with all our patients. You'll see it on the med-surg floor. You even see it on the cardiac wing where they just had open heart surgery, and they already have them out of bed, sitting in a chair, movement. And that helps prevent the formation of blood clots, because the blood is not just sitting there. It's not just stasis. When you move, your blood's moving. Okay. So now your patient is 5 weeks post-vaginal delivery. During the doctor's visit, the patient states that she notices foul-smelling drainage, pelvic discomfort, and she's been running a slight fever. The nurse relates these findings to which of the following? Which of the following would it be? Anybody? Okay, so let's look at what the question is asking us. This is what I want you to do on the test. Go back to the question. And okay, so the patient's complaining of foul smelling drainage. That means her lochia, guys, is foul smell.
Involution?
No, the involution wouldn't be foul smelling.
Oh, well, urinary tract infection, I guess.
No, because I got pelvic discomfort. So I got now foul smelling drainage. I have my pelvis is hurting. And I got a slight fever.
It's two.
It's two, endometriitis. The reason is, look up here in the question. I've got pelvic discomfort and I got a foul smelling lochia, drainage. When it comes out that's never good when you have a foul smelling. That means that up inside the uterus, which is the endometrium, that means there's an infection inside. And she has what we call endometriitis, okay? Is infection of the endometrium. So you guys write that down. Okay. All righty. Now, whenever you work in a hospital, you make sure that what? Proper hand hygiene is the primary method to avoid the spread infectious diseases, right? Or write that down. You're using, what are you using? You're using standard precautions. Write that down. You're going to need it. So gloves should be worn when in contact with any blood, body fluids, or any other potentially infectious material. That can be on any floor, med-surg, maternity, labor and delivery. Gloves are worn when we come into contact with blood and body fluids, because they all contain, they could have the hepatitis B, they can have hepatitis A, they can have any kind of infection going on. And so that's why when we take our gloves off, we wash our hands. And that is utmost in anywhere. Okay. All righty. So the object is to prevent the infection from recurring. I just kind of went over that, but on the maternity floor, we're talking about hygienic measures. We got to teach. Just don't assume everybody is doing what they're supposed to be doing. We want to promote adequate rest and nutrition for healing. Teach and observe for signs of infection. You know that lady that came in with the foul smelling drainage and the pelvic discomfort? She was told that if you smell something unusual and it's a kind of pungent odor, you got an infection going on. Sure enough, that's what that was about. Teach and observe for signs of infection, and teach the woman how to correctly apply peri-pads, and teach the woman to take all her medications, the anti-microbiotics, as prescribed. Now, a lot of people, especially women, we take a medicine, we feel better, and then what? We forget it. We don't take it anymore. When any patient, med-surg patient, maternity patient, anytime you want the patient to take the medication, if it says for 10 days, it means 10 days. If they don't take it for 10 days, let me tell you, they take it for a couple days, they feel better. Good, but it's not gone yet. But people don't know that, don't realize it. It's not gone, so you wanted them to take it for 10 days. You make sure you take it for 10 days. Because if it doesn't, what happens? It comes back with a vengeance. Okay, let's move on. This is another important topic. Hint, hint, mastitis is an infection of the breast. Okay, so here are your signs and symptoms. You have redness and heat in the breast. Tenderness, absolutely. They have edema and heaviness of the breast. I had a lady that she couldn't put her arms down. She had her arms up and she couldn't put them down because everything was so heavy feeling to her, and it's so edematous. It was awful. Even under the arm where you have we call the tail of Spence, that can get infected, can get edema, and it's very painful. Sometimes they can have purulent drainage. Infection gets so bad in the breast, it can turn into pus. Okay, and this one, they would definitely have to have an antibiotic. And the patient will have fever, chills, and other symptom signs, systemic signs of infection. And of course, anytime you have this kind of infection, you can develop an abscess. Okay, so she'll need some special care for sure, because it's very painful. I see here, here's your picture. And you can see where the breast is very heavy and inflamed, and you have a lot of redness. It hurts. It hurts terribly. All right. So which intervention should a nurse give to a patient to prevent mastitis and promote the flow of breast milk? So I want to prevent and I want to promote. Well, I would never tell, when we're a tight fitting bra, you want to, not tight fitting, because she is breastfeeding. That
They
was
said a warm shower.
Yes, thank you. Okay, you got it. Okay. I would definitely know that, guys. Okay. Okay. All right, let's go on. And because we always, nurses, we always want to prevent. Now, how about another question? A woman develops mastitis in the postpartum period, and she states, "Nurse, I'm so sad I had to stop breastfeeding my baby." The nurse responds, how?
Four.
Yeah, it's not necessary that you just continue breastfeeding. Yeah, the other three are totally inappropriate. I mean, I always, as a nurse, you want the best for the baby, too. So remember, breast is the best, and you can always breastfeed if you have another child. No, we have this child right now, and then I will inform your physician that you are feeling sad. Okay, no, that's this here nurse can take care of. And so she would say to her, it's not necessary that you just continue breastfeeding. Let me help you. Okay, so we went over some things here, and I told you what to take note to. You'll probably see them again. Now we're going to move into mood disorders. All right, so mood is a pervasive and sustained emotion that how you feel, how you see things can color your view of life. If you're very depressed, what color do you think you see? Be very dark, okay? Depressed people are very dark. Okay, now, postpartum blues. It is common after birth, but these are the blues. These are like mom feels tired all the time. She just has these certain periods. I mean, it's not like excuse me, it's not all the time. She feels like maybe she feels a little let down. Maybe she's overwhelmed. Yeah, but she does find pleasure in her new role as a mom. Women go home and they have to adjust to their new role, and sometimes you get overwhelmed. Doesn't mean you're blue all the time, but you can have certain periods of the day that maybe you're tired, and now you got to cook dinner, and you don't want to do it. You're just tired, and so that's what happens. And they have to really get used to it. This is common, guys. Baby blues. That's what I'm trying to get across. That's common. Is when, and here's my little cartoon. I think you all remember this. It's got a lot, you got a lot of things to do. This Mr. Life here, and life is telling you, you got a lot of things. You have to get out of bed. And so did things yesterday? When will things be done? And that's how sometimes you feel. You just feel kind of like overwhelmed. Now, when it gets a little more serious, you go into maybe more of a postpartum depression. So now this can show its phase around 4 weeks after delivery. And it's, like I said, it's a little more serious than your baby blues. And, sometimes the baby could be crying, but mom doesn't want to get up and handle the baby. okay? So it's a little more serious that after the blues, okay? And also you have to worry about maternal infant bonding could also be affected. So depression can occur, is not as common as the baby blues. But if the baby blues don't seem to get better and mom doesn't get support or help, then what happens to her? She goes up, she's still getting overwhelmed, and now she's going to go deeper into that dark hole. So you don't want her to go there. So we want to get her some help. Okay, so I would take note to postpartum depression. Everybody got that? All right, so postpartum depression is an expected reaction following childbirth. Is that true or false? Anybody?
False.
False, right? Because it's not an expected reaction, right? The baby blues is expected reaction. Depression is now going into a different realm. Not everybody gets the postpartum depression. Is a little dark, is much darker than say the baby blues. Okay, does everybody have a clear picture on what that's all about? Okay, so here's a picture of mom who's going into a bad area and she's getting postpartum depression. Okay, and yeah, like I said before, sometimes the baby could be crying and mom's just not reacting. That's not good. Now, you go a little deeper into that hole and you go into what we call postpartum psychosis. So these can happen, and research has shown that shows that people who are bipolar disorders have, they have episodes of mania that can get this after delivery, postpartum psychosis. It's a deeper feeling of worthlessness, guilt. Their sleep and their appetite are just really disturbed. And the main thing with psychosis is that they hear voices. So the voices could be telling them to what? To kill their baby, infanticide, to kill themselves, suicide. These people are prone to all this. So they can't be left alone when they get into this depressive state. They cannot. And I tell you, I took care of a lady. I was a new nurse on the postpartum floor, and she had postpartum psychosis. But nobody told me at the time. I was a nursing student. I was it's my job, but I was working on the floor, and I was her sitter. It was very scary. Let me tell you, it was very scary to be there. So what is the nurse concerned about with a patient who has postpartum psychosis? You have to worry about right here, suicide and infanticide. Because when she is in the depressive state, they can get really bad. Okay. And these things are real. They're not just in a book. They do happen. Okay. So let's go on now to chapter 12. So recapping chapter 10, please take note to uterine atony and the medication that we use to control it. How do we prevent fundal displacement? We don't want that fundus to be displaced, right? We want to get her up to go to the bathroom, or let's get that bladder empty. If she has a foul smelling vaginal discharge, that's an infection. We talked about mastitis, and we want to prevent mastitis. We talked about vulvar hematoma and how painful that is, unrelenting pain. Okay. We talked about preventing a DVT, get them out of bed, early ambulation. We talked about postpartum psychosis, and when they're in a depressive state, we're worried about suicide and infanticide. And we talked about hypovolemic shock. Okay, so let's move on now to the newborn. Okay. All right. Now, this is the term newborn. So let's review our reflexes. So these reflexes here, we say these are reflexes that help keep the baby alive. Okay. So blinking, sneezing, gagging, sure. Sucking and grasping. These all help to keep the baby alive, including, crying, swallowing, and lifting their head. But again, these reflexes are indication of the neurological system, the nervous system. So again, these are reflexes that keep a baby alive. All right. Because without sucking, they can't eat, right? Without gagging, they could be choking. And sneezing, whatever fluid they have, because baby's born with a lot of fluid, they get the fluid out. And blinking is protect the eye. So you have those great reflexes. You have the other reflexes we have, or the Moro reflex, which is your startle reflex. Rooting, anything that touches the cheek of the baby, the baby's going to root toward that area, such as maybe anticipation of eating. You're going to feed me? That'd be great. Tonic neck is a postural reflex. And then dancing, the little feet go up and down, look like dancing, really cute. But what happens the bottom of their foot hits a cold surface, boom, and they go back, and they touch it and they reflex, they go back up. And Babinski, everybody likes the Babinski reflex, so does test takers or makers. So Babinski, when stroking the soles of the infant foot. So write that down, that reflex Babinski. Okay. Respiratory. So remember, once the umbilical cord is cut, baby's on their own. Yep. The baby's lungs now take on the functioning of the breathing oxygen and removing carbon dioxide in and out. They have to have that surfactant in their lungs. Remember that? Okay. Remember, preemies, they don't have so much for surfactant, right? So they're more prone to having problems at birth with breathing because they don't have. Respiratory. It is. Its most critical period in the baby's life is that first hour of life. You gotta make sure he breathes good. Newborns, they can be put on their back or their side to help maintain. What you want, guys, is you want a patent airway. So you want to put a baby on their stomach, right? You want them to be able to, if they start to spit up, that they don't aspirate on their own spit up, their own vomitus, that at least if they're on their side, which I prefer, on their side, it helps keep that airway open. Okay. All righty. Now here, this is always a good thing to have on a test, is how about bulb suctioning. Nurse ensures that we have a patent airway is maintained through correct positioning of the neonate, remember, on his back or side, and removing any mucus from the mouth and nose with a bulb syringe. So here you can see the bulb syringe, okay? And we don't put the bulb syringe right into the baby's mouth, straight in. Because when you did that, you would make the baby's reflex, gagging reflex, would start, okay? So you always want to put the bulb syringe on, like here, you see here on the side of the mouth. That's the proper way. All right. All right, so I know that we've all gone over APGAR scoring, and again, it's just a standardized method of evaluating newborn's condition immediately after delivery. You do it at 1 minute and you do it at 5 minutes. And what we're looking at is the baby's heart rate, respirations, muscle tone, reflexes, and color. So if you don't have a heart rate, you get 0. If you got a heart rate of less than 100, you get a 1, and because he's got a heart rate, at least. It's maybe not enough, but he's got a heart rate. And then if he has over 100, he gets a 2. So We assess that at 1 minute and 5 minutes of what you're looking at is you want to see if there's any, what you're looking at too, when you're assessing and giving the APGARing, you're looking at respiratory distress. And in a baby, respiratory distress is seen by the rate and character of respirations. Okay. You're looking at the color of the baby. Now, acrocyanosis is a normal thing. That's where the hands and the feet are blue, but the rest of the body is pink. That's called acrocyanosis. Now, that can happen because remember, we've gone from intrauterine blood circulation to extrauterine blood circulation. So those are shunts in the heart have to close, and that takes a few seconds. And so what you want to do is sometimes getting blood out to the peripherals takes a little longer. So getting it out to the hands takes a little longer. Getting it down to the feet takes a little longer. So these babies come out, they can have bluish on the hands and feet, but it does go away.
On the counter like that, the thing you scrub the sun where you left.
Okay, go ahead and mute yourself. And then sternal retractions, write this down. Sternal retractions is never good. Okay, that means the baby is breathing hard and really to get air in and out. So sternal retractions, chest retractions are never good. Okay, and must be reported. So that's always a good question. All right. Obtaining temperature, pulse rate, and respirations. When you're taking a baby, now we usually take it in the axillary. Very rarely do we see any rectal anymore. Now, if it's done rectally, it's done by the nurse practitioner or the pediatrician, because there has been problems with nurses doing that. So we take it axillary. And pulse and respirations are counted before taking temperature. Because just think, you got a baby, and a baby's sleeping, and now you're going to do his assessment, take his vital signs. You don't want to, you want to hear the heart rate. So you got to keep that baby nice and calm before you take a temperature. So is that kind of like when an adult, with adults you take temperature first. With a baby you do what? You're going to check his respirations and his heart rate first, and then you're going to basically take his temperature. And then the nurse should report, any kind of elevation of the temperature, pulse rates, greater than 160 or less than 110. Because remember, normal is 110 to 160. Respirations greater than 60 because it's really breathing kind of fast there, or less than 30 because it's slow. So I would take note. I would know the normal vital signs of an infant, and that's really good for HESI. And then you want to take note to any kind of noisy respirations. Do I hear any grunting? Do I see any nasal flaring? When a baby has his nose and it's flaring out, that's he's having some problems breathing. And then, of course, chest retractions or sternal retractions. Okay. So let's see. When the nurse is doing her morning assessment on a baby who was born during the night, what physical signs should the nurse report immediately? And we can go right back to this one. And this is what you would report immediately, correct? Okay. All right. Remember, thermoregulation is very important. Maintaining body temperature of a newborn. Keep them out of drafts. Keep them off cold surfaces. You don't ever want to cold stress a baby, right? And if you don't remember cold stress, then I would go back in the book and look up cold stress, but they work really hard to keep their cells warm. So they can use a lot more blood sugar up. So they could get hypoglycemic. Also, they can have respiratory distress syndrome because of cold stress. So you don't want to ever cold stress a baby out? All right, if you don't remember cold stress, please look in your book on the cold stress, okay? All right, let's go on to skin. Skin, okay. So we always look at the turgor and overall skin condition. It's usually covered with fine hair. What is that called? Langugo. Langugo, exactly. I would know that. All right. And also, Vernix caseosa. Remember I said that's the nature's cold cream, okay? And it protects the skin from like irritation, affects, because the baby's in a watery substance, and his skin can just peel right off. Remember, just think if you were in the pool and you were in the pool for 10 hours, what would you think your skin would look like when you came out of that pool? It can really get very irritated. So that's why the baby has this Vernix caseosa, and that we call it like the nature's skin cream, okay? And then you have to be looking at the skin too for jaundice. And remember, we have two types of jaundice. We have pathological jaundice, which happens in the first 24 hours of life. And then you have physiological jaundice, okay? And what you see when you have physiological jaundice is that you have like a yellow tinge to the skin, okay? And what's happening is that it's caused by the rapid destruction of red blood cells, or too many blood cells. Too many blood cells, the liver can't break down enough bilirubin, and it makes the skin turn yellow. So we want to make sure that we stay on top of that. Though physiological jaundice, we can see it in most babies, okay? But we have to act upon it. So it could be that the baby would be under some kind of phototherapy, or sometimes, especially if you live in the South, and especially if you live down in Florida. I mean, most of the time we have a lot of sunshine down here. We tell moms to take the baby outside and let the ultraviolet light get out. I'm talking about skin conditions in newborn. Okay, so I want you to take note to this one. This is called Milla, which is your white pinpoint pimples, okay? Take note to that. Yeah, and you know what happens? A lot of times moms can get very upset because they're looking at their baby, you should know, and they say, oh my God, my baby has acne. It's like, no, baby doesn't have acne. Everything's okay. These are normal, and they go away. The fine hair on the body of an infant is called langugo. Now, Mongolian spots, they're bluish discoloration of the skin. And they're found normally over the sacrum and the gluteal areas. Okay, so it does happen. They will fade out, but they never really go away, but they will fade. So, moms sometimes think, oh, I can put a cream on the baby's skin and they'll go away. No, they won't go away. And then you got Vernix. And then you have what we call port wine, and that's like a nervi inflammation. It's a collection of capillaries under the skin. So these are skin conditions that can occur. And usually moms are very upset about skin conditions. All right. Gastrointestinal, they function shortly after birth, okay? We know meconium is the first stool, and it's a mixture of amniotic fluid and intestinal gland secretions. Amniotic fluid and intestinal gland secretions. So if the baby is born, his first bowel movement should be around 8 to 24 hours after. Well, sometimes they do a lot more, especially if you're assessing the baby and all of a sudden it gives a little squirt out and that's the meconium. It's like, let me tell you, it's like tar. It's real thick. And so as I said, see here they say sticky. Yeah. And then the stool would change as the baby gets, going and eating a little bit, then the stool will change. Now, the color and the amount and consistency is depending upon what the infant is fed. Like breast milk, now write this down. Breast milks, the stool of the baby will be yellow, and sometimes it's a little grainy, but it's mostly yellow. And then formula is a little bit different too. And I think I have a picture here. Let me show you right here. And this comes from your textbook, right out of your textbook, where you can see. But here's your first meconium stool. Okay, you can see how it would be looks sticky and tarry. Yeah, it really is. And then here's your meconium after breastfeeding. It started to break down. And then now we're going to go as the day more stool will come out. It does change, go into the it's all according to the intestinal flora. And then you have here changing into more of a breastfed stool. You can see it's yellowish. And then you got a normal breastfeeding stool right here. It's yellow and has looks really yellow grainy. And you can see the difference in regular formula fed versus, breastfeeding here. Now, just to give you a little tidbit here, you can see the little constipated stool. He's less. Babies can get constipated. So we have to make sure that the baby has a good amount of stool. And on the postpartum floor, your mom will, when she changes the baby's diaper, she'll check off on a checkoff list what color the stool is, what time it happened, and so that we can keep track of all that. Okay. So if I was to ask you, is it a normal finding if the stool of a breastfed baby is yellow? Yes. Yes. Okay. All right. So we're going to talk a little bit about immaturity of the immune system. Okay. So babies are born with passive immunity. Okay. So that's why we don't want taking the baby out to the mall, these places where a lot of people come together, all kinds of people, all kinds of germs, because the baby's immunity is not the greatest right after birth. And mom breastfeeds, it'll get better. Okay. So everything in a newborn is immature. Everything. Okay. He's got everything he needs to live outside mom's womb, but it's all going to mature. Like the liver, for instance, the liver is not mature at birth. It's there, but it's not mature. That's why sometimes babies can get jaundice, because the liver can't take hold of all the maybe excess bilirubin that's being secreted by the breakdown of the erythrocytes. The umbilical cord stump can be a primary site of infection. Oh yeah, it has to be kept clean. Okay, so and it will dry up and it will fall off. Okay, but it has to be kept clean because you don't want to get infection there. And what did I say before to you about hand hygiene? It is the utmost primary means of preventing infection. Okay, you'll probably see that again. All right, let's go on. So we went ahead and talked about chapter 12. And on chapter 12, just recapping to make sure that everybody has it. We talked about the Babinski reflex, the stools of a baby, and breastfeed baby, especially is yellow. We talked about Mongolian spots, cold stress, Mila, and we talked a little bit about surfactant, but I'll talk more of that in the preterm baby. But all babies have to have their surfactant. And then Another problem with newborns too is the sudden death syndrome. And that can happen when a baby has maybe too many blankets in the crib, or the baby's put on the prone position, or toys in the crib. Everybody likes to decorate the cribs with all these kind of cute little things, but all that can contribute to sudden death syndrome. So you want to make sure that you teach your patients not to have these extra things in the crib, because it does happen, unfortunately. Okay, so let's go on now to chapter 13. And this is on the preterm and post-term newborn. Okay, so when we classify babies, we're looking at, what was the gestational age? Okay, or what is the gestational age? So like a preterm infant is less than 37 weeks, because remember, term goes from 37 weeks to 40 weeks. That's a term baby. And then you have the new term called late term infant, between 41 weeks and 41 weeks and 6 days. Now, if you have a preterm infant, because we know when term is less than 37 weeks. Okay, remember, viability is 20 weeks. So you have a preterm, or you're going to have between 20 weeks and 36 and 6/7. Okay, so it's less than 37 weeks. Now, early term is between 37 weeks and 38 weeks. Again, we're going with term. See here, term. Then we got full term, which is between 39 weeks and 40 weeks and 6 days, because that's how we do the days of the week. And then late term is between 41 and 41 weeks and 6 days. Now, when you get to this post term, okay, now we've gone, these were all, you notice, these were all classified in terms, but they had early, full, and late. Now you got this baby who is post-term, okay? This baby's really late. This is a baby that's after, put it this way, after 42 weeks and beyond, which I never want that to happen, because the placenta can really get calcified and get really old. Okay, so everybody got the definition of a post-term infant is after 42 weeks, 42 weeks and after. Okay, and a preterm infant is less than 37 weeks. And then all this is all about term babies upon how they come. Okay, I would remember this. All righty. So I guess here, right, to ask you this question, which classification will the nurse assign an infant born after 42 weeks gestation? Which one would I be assigning to this baby?
B.
B, post-term. Good. Okay. Good. Okay, so we're going to talk a little bit about surfactant. So what it actually, we talked about this before. You need this like lubrication. I kind of say like lubrication of the lungs, because what you want to do is you want to be able to absorb oxygen. Lungs go in and out. Think of that. So what surfactant actually is a fatty protein. And it's high in lecithin, which it is necessary for the lungs to what? To grab onto those molecules of oxygen. Okay. So I put it in here because I don't think, if you remember from fetal development, it's usually formed around 24 weeks gestation. And by 34 weeks, they should be able to deliver, it should be breathed adequately. Now, if you got a 26-weeker, okay, this surfactant may be very low in this 26-weeker because he's early, okay? Because remember, the surfactant just started to secrete at 24 weeks. So they don't have a lot of this fatty protein to grasp on to the oxygen. So therefore, they're at loss, okay? So these babies that are born prematurely, they need help. So they'll need maybe some surfactant after birth. Now, what we can do for mom is give her beclomethasone, and that's a steroid, and it's in 2 doses, 24 hours apart, and that increases the production of surfactant. So when this baby is born, he's got that little extra help. Now we can do that, and we do it, and it does help these babies. And these babies, because they're so early, when we get them in the NICU, we go ahead and give them surfactant through the ET tube. They get intubated, so they don't have to work so hard to breathe. And then through that ET tube, we can give them surfactant. And that helps really with gas exchange. So, you know, we don't want these babies to work really hard because they can get what we call hyaline membrane disease. And also it's also called respiratory distress syndrome. So we want to be able to help these babies breathe. And I hope that you were able to see that video of little baby Griffin I put under announcements. It's really, it shows you a premature baby and how the care of the NICU helps these babies. They grow, they can breathe, and they eventually go home. It's really a nice little video. So I hope you just take a few minutes to watch that. Okay. So if I was to ask you, which complication will the nurse assess in a preterm infant who is deficient in surfactant? Okay, so think of these 4 here. Which complication?
D.
D, exactly. You got it. You put it together. Good. All right. So we're going to talk about a little bit about RDS, respiratory distress syndrome. So we're always monitoring vital signs. And when you have a baby that is having difficulty breathing, they have to be paired a little different because they can't be handled a lot. Because when you hold a baby or you stimulate a baby or you're doing anything on a baby, he's going to what? Going to maybe breathe a little different. So we call this cluster care to minimize the handling of an infant to help conserve energy. Okay, we don't want him to lose a lot of sugar or because we're handling him too much because he's using a lot to move. Okay, everything is very hard on these preemies, and so you got an IV in them, and then you have to be careful that you don't overhydrate, or you want to make sure that you got them on a pump. Oxygen therapy. Very carefully do we give oxygen because they're at high risk for too much oxygen. And so we can actually hurt their eyes if we gave them too much oxygen. So we want to make sure that they're on a pulse oximeter so that we only give enough out, okay? Be very careful when we're giving oxygen. Because again, they can get a condition called bronchopulmonary dysplasia. Big word. This is all respiratory, bronchopulmonary and dysplasia. So what happens, and this is dysplasia, remember, difficult, it's a toxic response of lungs to oxygen therapy. You can actually give too much oxygen and actually cause atelectasis, edema, and sometimes even thickening of the membranes can interfere with your ventilation. So again, you want to be very careful that you don't give too much oxygen. Years ago, we used to give a lot of oxygen. And so now with the pulse oximetry on babies that we've had for the last 30 years, it's much better. I highlighted something on this slide, and that's a hint for you. So you want your saturation levels 92% or above is normal. Again, saturation levels of 92% or above is normal. So if you have a severely anemic infant who may have severe hypoxia, you want to make sure that you've got a little pulse oximeter on, okay? Remember, these conditions such as erythroblastoma fetalis causes the infant to be severely anemic, and which then can lead, because they have less red blood cells because they're anemic, they can have less circulating oxygen.
Is that a SpO2?
Yes.
Oh,
Same
thank
thing.
you.
Yeah, 92%. Yeah, it was nice when the pulse oximeters came out. Oh, look at this question, Winnie. So here, the nurse is assessing the pulse oximetry on a preterm infant. Which of the following indicates normal reading, guys?
D.
You got it. All right. Okay, well here, we talked about cold stress before, and I said to know it, and sure enough, here it is again. So here's your signs and symptoms of cold stress. It's never good. Cold stressing a baby is never good. They use so much oxygen up trying to keep warm. So what happens is that they have a decrease in their skin temperature. They're cold. Remember, cold. Okay. Have you ever been up north? I guess you guys are from up north, right? You live up there. You when you go outside, your skin temperature goes down. You're cold. Don't you breathe heavy different when you're cold? You have increased respiratory rate. Okay. Same thing with a baby. Baby's laying there, poor little thing in the crib. He's got maybe a window open, it's cold, it's maybe 20 degrees out. He's gonna get cold. He's just laying there. He's going, somebody help me, somebody cover me. Okay. So he's gonna increase his respiratory rate. His heart rate goes down, bradycardia. And look at that, changing of the skin. It's called modeling of the skin. That happens when a baby is cold stressed. And then if his heart rate goes down, he's just like, okay, I'm really working hard here, but nobody's covering me up. Somebody give me give me a blanket. Okay, all right. So you got the notion of cold stress, right? Okay. So which of the assessment findings will the nurse associate with cold stress in a preterm infant? Okay, we talked about this. So be A, right? It wouldn't be tachycardia, it'd be bradycardia.
It's A, C,
Yeah, so C, the skin temperature goes down.
and D.
And D, tachypnea. Yeah. He goes, I'm cold, get me out of here, help me. And sometimes they get so tacky that they actually can lose their breath, be without breath. And they're not excitable, they're a little more fatigued, right? Okay, so you can see how these questions could be asked. So remember, here it is. Decreased skin temperature, increased respiratory. Trying to warm them. He's trying to warm himself up. Heart rate can go down. The skin could be getting this little modeling look on it. And then you have a baby who is lethargic. Okay. And that's how these questions are asked, just like this. That's how
Is
they're.
lethargic part of that?
Yeah, lethargic, they're not excitable. They're tired. They're lethargic. I've been, why too? How do you remember this? Is that he's working really hard at keeping himself warm by increased respiratory rate. So what happens is he gets tired. It's a lot of work. When you're trying to keep yourself warm, it's a lot of work and you can tire yourself out. Okay, let's move on to jaundice. All right, jaundice. Well, we want to prevent this because you can get kernicterus from too much bilirubin. So you want to prevent kernicterus, all right? So we're going to make sure that we look at the baby's skin. All right. And also you can see jaundice in the eyes. It's pretty bad when you have yellow eyes. So I'm going to look at his skin mostly, right? I'm going to look at the sclera and the mucous membranes. These are all pretty good ways to look for signs of jaundice. And you're going to report the progression of jaundice. Okay, so how you report it is if you start at the face, you go to the abdomen, and then you go to the feet. Now, if this baby's got that much jaundice, we're in trouble, okay? Because that's a lot of jaundice, to tell you the truth. So we want to always prevent kernicterus. And you're going to, get labs. You're going to, you're going to wash this baby, and this baby is going to be on phototherapy. Phototherapy. Write that down. The treatment for the jaundice is called phototherapy. All right. So I think I got a picture here for you. Here it is. Here it is. This is phototherapy treatment of jaundice. And here we are. Nice little warm incubator. Because, again, this baby is naked with a little diaper, maybe something here to get the excretions. But he's under ultraviolet lights, and it's going to be on the total body. So that's what we want. We want that bilirubin to go down. So we're going to, this is how we break down the bilirubin that is circulating, and how it comes out of the baby's body is through urine and feces. So that's what we want to make sure this baby has a little diaper on. And then you're going to be laying in this ultraviolet environment, which is very, very, very bright. You want to cover the baby's eyes. You always want to cover the eyes, protect his eyes. So, special needs. These are my goals for a preterm infant, okay? Preterm infant. These are my special little babies that are born too soon. So I want to improve their respirations. They are born with less surfactant, which causes them to have more respiratory distress, okay? And so I'm going to improve their respirations. I'm going to maintain body heat. Preemies are even more prone to, being cold. And I want to cold stress a pretermer. That would never be good. And so I want to maintain their body heat. So I'm going to know their temperature. With a preemie too, a lot of times we, especially in the NICU, they'll put like a probe on the baby, and it hooks it connects right to the radiant warmer, and we can monitor their temperature real good. Because you don't want to overcook a baby, and you don't want to undercook a baby, right? You want it just right. So I'm going to put this probe on. It looks like a little shape of a heart. And where you put it on is on the baby's right side over where his liver is. And that's where we can pick up a good body temperature. And so then we know that we got the incubator or the warmer on the right temperature. I want to conserve energy. So that's why I'm going to use cluster care, because when they're working hard, they're going to use a lot of energy. They're going to need that. And I want them to conserve the energy because they have to get better, okay? These little guys have to grow, so they have to get better. And so I want them to have all the energy to go that way, to get to grow and to get better so they can go home. I always want to prevent infections, so good hand hygiene, wearing gloves when necessary. And when people come in, like mom and dad, they got to wash their hands. They have to do a 5-minute scrub prior to going into the NICU. Because they could be anywhere, right? And anybody who's sick, they don't go into the NICU. If you got a cold, mom or dad has a cold, they're not going into the NICU. So you want to provide proper nutrition and hydration. So sometimes they have an IV for hydration. And then proper nutrition. If they're real preemie, they're going to have probably the breast milk through gavage feeders. And that's a tube that goes right into the stomach. And your responsibility, okay, now write this down, with gavage feeding is that you want to make sure that you aspirate a little bit of the gastric contents before giving the next feed, before giving the feed. The reason why you're doing that is that if you get a whole bunch of gastric contents, that means the baby hasn't even utilized the last feed that you gave, so that you wouldn't want to put more into his stomach, because their stomachs are really, really tiny. And so you don't want to do that. So the nurse does what she does is make sure that there's not very much in there. So they recorded, they got maybe 2 mLs out, and then they can feed. If they had more than that, like they have a whole bunch, then you would call the doctor and say, I went ahead and aspirated and I got some X amount of cc's of gastric contents, and you want me to hold the feed at this time. Okay, so that's what's important about gavage feeding. It's other than that, you always want to make sure it's always properly placed, so it's in the right place. Okay, giving good skin care is utmost for a preemie. They don't have a whole bunch of brown fat on them, and so you want to make sure that the skin is intact. There's no openings or dry skin. So it's good skin care. And then observe the infant carefully and record all your observations. And always, 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 you want to support and encourage the parents. It's not easy to have a preterm newborn. It's always, when I worked in the NICU, it was always a touch and go. Okay. And then as we got further, a couple of weeks from the delivery time, things look up, looking better, mom, dad. Baby's maintaining his body heat. His respirations are more normal, and all this goes into play. And so the main thing is to get them so they grow a little bit so they can go home. That's the main thing. I talked about already gavage feedings. I would take note to that. And if you need to, it's in your chapter. Please look up the gavage feedings. The main thing is to aspirate before giving the next feeding. All righty. And breast is the best. Always. Okay. All righty. And know that feedings always reduce the risk of hypoglycemia, because you don't want these babies to have low blood sugar. It also, you want to have the feedings too, because you want to break down that bilirubin and you want to prevent dehydration. Fontanelles that are sunken, the fontanelles on the baby that go down, they're sunk. That's indication your baby's dehydrated. If you have a fontanelle that's bulging, that is an indication that you got maybe some intracranial pressure that is never good. Okay. So which nursing action is most appropriate prior to starting gavage feeding on a preterm infant? Oh my goodness, I just went over this. How about that? Which one, guys?
D.
D. Very good. Good. You got it. You did it. Okay. So this one's here. We're going to go to now opposite. We're going to go to this post-term baby. And this post-term baby is a baby born 42 weeks and beyond, right? So this baby's been in there too long. He's cooked too much. And these babies can have problems. They can be big babies, so they can have a difficult delivery. These babies could have already passed his meconium in utero, and he is at risk for meconium aspiration syndrome. Okay, so what that is that the babies that already had their first bowel movement in utero and now are coming out, and so the head pops out. Okay, you have to suction these babies right away. So we get wall suctioning. We don't, do don't use a bowl syringe because meconium, like I showed you before in that picture, is thick, it's tarry looking. So what you want to do is get that wall suctioning in, and we suction as much as we can in the mouth. Okay, we don't go deep at this time. We get whatever's in the mouth, get it out. We don't want this baby to take his first breath. Then we take the baby over to the warmer, and the warmer has been on, so it's nice and warm for the baby because we don't want to cold stress this baby. You have respiratory therapy and you have the NICU nurse. Okay. Now the respiratory therapist is in there. He's going to intubate this baby, and then we're going to suction again, and this time go way deep into the stomach and get that meconium out. The more we get out, the better it is for this baby. If this baby was to take a breath before we did any of this, okay, any of the suctioning, then he could aspirate on his meconium. That stuff, like I showed you that picture, that tarry brown stuff, thick, can get into his lungs. It can cause a lot of damage to the lining of the lungs, and then he would have definitely be very, very sick baby and have respiratory distress syndrome. So we don't want that to happen. These kids, when they take in their own meconium like that, they aspirate on their own meconium, they're very sick babies, and they're in the NICU for a couple of weeks because they're very sick, because they can get all that gunk in their lungs. They can't breathe. They have infections. So you don't want anything like that to happen. So that's why we try our best at the time of delivery to get all that out. Babies too, post terms can have poor nutritional status. These can be very big babies. They may have increase in red blood cells, but again, they've been in there a little bit too long. I talked about difficult delivery. They could have a broken clavicle because maybe they had shoulder dystocia, where the head came out, but then the shoulders were stuck. Okay. And once the head comes out, guys, there's no pushing that head back up in the vagina. No, you have to deliver the baby. So you have to probably, as a practitioner, you have to cut a 4th degree episiotomy, open up the whole pelvic perineum there to get the head, to get the shoulders out. And then what happens, a lot of times you have to break the clavicle on the infant for the shoulder. Once you break the clavicle, the shoulder, it goes down, it goes really loose, and then you can manipulate the shoulder through. Never good. Birth defects are seen more on post-term babies, and these babies can actually have seizures. Okay, so how are you going to do nursing care of these post-term babies? Well, you always want to look for respiratory distress. Sometimes hypoglycemia, especially to a diabetic mom, gestational diabetic mom. You want to make sure that you're watching out for hypoglycemia. Anything under 45 milligram per deciliter is considered hypoglycemic. When you get to like 40 and below, you can run into big trouble. Okay, so yes, it's never good. Hyperbilirubinemia, they have an excess amount of red blood cells. They're going to have an excess amount of breakdown of those red blood cells in the bilirubin, and this can cause you to have jaundice. So these babies are prone to a lot of different things, just like preemies, and of course, cold stressing. You don't want to cold stress that baby out either. Okay, the cold stress is never good. Okay, so I already went over this. I talked about the fontanelles. You have an interior and you have a posterior, and you have a infant with a sunken fontanelle, that's dehydration. And then you have a nurse that says an infant with bulging fontanelle, that could be maybe due to hydrocephalus, bulging fontanelle, where they have increased amount of cerebral spinal fluid. Okay, so that was that chapter. And on the post-term and preterm baby, and that was chapter 13. Okay, so to recap, I talked about the SO2 rate of a baby, 92% is normal, 92 and higher is good. Gavage feedings we went over, phototherapy went over. And we went over Babinski reflex, yellow stools on the babies, meconium. We went over meconium aspiration. We went over Langugo. We went over Milla. We went over colstress again and meconium spots. Okay. All right. So now we're going to head into chapter 14. All right. So this is our last chapter, I believe.
I have a question. I didn't get the point you talk about the two questions you asked, the last two questions for the brain teaser, the
Yeah.
anterior and posterior. I didn't get that clear. Can you just go over it, please?
Sure, no problem. So on
Thank-
the baby's head, there's two fontanelles, okay? And you might have ever heard of somebody maybe referred to on the baby's head like a soft spot, you know? Be careful of that soft spot. That's where the skull hasn't come all the way together. So the two fontanelles, you have interior and posterior. Okay. And so if you're looking at the baby's fontanelles, and all of a sudden you feel this fontanelle is sunken in, like it goes inward. That's called sunken fontanelle. That could be very indicative of your baby dehydration. Yeah, never good. So the baby that's maybe been sick, been vomiting, a preemie baby could have a sunken fontanelle. That means she needs an IV. Okay, dehydration, never good. On the other hand, you have another baby and you're assessing and you got a bulging fontanelle. So we don't want bulging fontanelle because that means there's too much fluid under the scalp. Okay, it's too much fluid in the head. So that's never good. And that's seen a lot with hydrocephalus. They have bulging fontanelles because they have an increased amount of cerebral spinal fluid. So we don't want fontanelles that we don't want them sunken and we don't want them bulging. We want them, we call just right. Is that
Okay.
it? Okay, you
Yep.
good?
Yeah,
Okay.
thank you.
Yeah, you're welcome. All right. So now let's go on to chapter 14. Okay. Remember, you know, these are all going to be on your tests. So I want to make sure that we cover everything. So let's go on. Let's discuss some of these. And this is a hard chapter, honestly, because, you know, we want babies to be just perfect. Okay. But sometimes there are some birth defects. And so sometimes there can be present at birth. Some are called congenital malformations, and they could be a product of an inborn error of metabolism, such as the maple syrup syndrome. We'll go over that again. Disorders of the blood, chromosomal anomalies, and perinatal injuries. So let's go over all these. So I asked you a question a couple of days ago about this: active and efficient participation. In other words, going to the doctor and getting some prenatal care. Can that significantly decrease the risk of congenital anomalies?
Yes.
Yeah. Remember, good care, healthy moms equal healthy babies. Absolutely. Absolutely. Okay. So now these are some malformations that can be present at birth, and these can be under the nervous system. So we talked about the neural tube defects. So what happens in the neural tube, it doesn't close. And during the embryonic state, it has to close. But if it doesn't close, then we got an opening. And it can have an opening either in the top of the head, the cranium, or at the end of the spinal cord, okay? And so if it's on the top of the head, it would be hydrocephalus. And then if it's under the end of the spinal cord, that's your malformation of spina bifida. So mom takes folic acid, it reduces the chances of having an open neural tube defect significantly. And that was very, very good research that came out. Okay, so here's your baby with a big head. He has too much cerebral spinal fluid in his head. His fontanelles are bulging. And so this is never good, okay? And his eyes look like they're ready to pop out, you know? And so he's got a big head, and it's hard for these kids. And the main thing is when you feed these babies, you have to support their head. Because just think, you know, just sit in your chair and just think if you had 100-pound head, all right? What would your head be doing all the time? You know, yeah, it would be hard to balance that head. It'd be hard to eat. So just think of a baby laying there with his big head because we've got too much cerebral spinal fluid, and you're trying to feed him. You got to support that head at all costs. Okay. All right. So what you're looking at is the classical signs. So the classical signs of hydrocephalus is increase in the size of the head, as I just went over. The cranial sutures, they have to, you know, these sutures that we talked about before, they have to open up a little bit because they have this mass, this fluid that's causing pressure and that is enlarging. So it has something, the fluid has to come out somewhere, right? So if you don't have a shunt in, what happens is that these cranial sutures can actually open up. As you saw in that picture, the scalp is very shiny and the veins are dilated. And I know in your book, you have a really good picture of a baby with that and how he's laying there with his head. Okay. All right. So if I was to ask you, which assessment finding will the nurse expect for an infant diagnosed with hydrocephalus? Which one would it be? Anybody?
2.
2, large and rapidly growing head. And while we're here, let's just look at the others, okay? So for hydrocephalus, that's what the question was asking me. It would be large and rapidly growing head. If you had a protruding tongue with a short, thick neck, that would be what? Down syndrome. If you had an inward turning of the ankle or foot, what problem would you have there? Clubfoot. If you had a hairy patch in the lumbar sacral regions, what would you have?
Spina bifida.
Spina bifida occulta. Yes, good. Okay. Okay, so here are your symptoms of increasing intracranial pressure. So you have increased blood pressure. You have a decrease in pulse. You have a decrease in respirations. And these kids, guys, have a high-pitched cry. You see that a lot with babies that have malformations and have problems. They have a high-pitched cry. This baby, as you saw in that picture, he had unequal pupil size, or a response to light would be different. The baby with increased cerebral spinal fluid has bulging fontanelles, and I highlighted that for you. Headaches in children due to closed cranial sutures, irritability, lethargic, vomiting, and these babies are also poor feeders. When an infant is a poor feeder, you got a problem. All righty, moving right along. Here I wanted to show you the picture. This is how we keep the fluid in the head down, is because we put a shunt. Now look at the shunt. Here's your tip, and it's in the ventricle of the brain. And it's put in, now this is surgery. So it's put into the ventricle, comes down, this is a tube. This is a pump that sometimes we have to pump it, you know, to get the pressure going. And then here is another tube, and it goes right into what? The peritoneal cavity. All right. So that, because you can handle fluid down here. So this helps a lot of people to live a decent life. Now with children, babies, they put it in, And then they had to go back in and do, surgery over and over again. These kids go through a lot because they grow, children grow. And so then their needs grow. But again, you can live a good life. They're more prone to seizures, but you give them some Dilantin and prophylactically, and it helps with the seizures. Okay, now the other open neural tube defect is your spina bifida. Okay, so I would take note to this one too. You'll see it again. Here, you don't have, this is where the tuft of hair would be in this area on the skin, because you don't really see too much on the outside. Okay, so here's your spinal column canal, here's your spinal cord, and then the meninges. And then you have what happens, you have a defect in the bony canal. What happened? It didn't close. There's an open neural tube defect. And so here, it wasn't so significant. It was called more of a occulta. And the occulta is, you can't see it. Okay, so you can see this here. And then you have this one here, and this one, it has the what? The meninges are protruding. You have the little sac. You have the defect, right? And here's your spinal cord. Okay. And then we go into the meningomyelocele over here. And here you see the defect in the bony canal. The meninges are protruding, and along with the meninges is the what? Spinal cord. Okay, now that's about the worst. And I guess you can see that's about the worst, right? This one, on this here and this here, you have to protect the sac. All right, the sac has to be protected at all costs. So you wouldn't have this baby laying on his back. Okay, you have it on the side or on his stomach, but not on the back. You have to be very careful. Now, when anything such like an organ is outside of the body, you have to protect it from drying out. So how are you going to do it? And this one here, the meningeal is, this is called the meningeal. This one here, you're going to put a nice sterile towel over it, and you're going to have it with saline. Keep it moist, okay? Because if you don't, it'll dry out and it'll die. So you don't want that to happen. And so because these children will go into surgery and to correct it as much as they can. These children here, meningomyelocele, you can see the spinal cord protruding right in here. See here? Yeah. Wait, it doesn't do it here. These children have, they lose a lot of their body functions, such as bowel and bladder. So they have to go to a special place called habituation and like rehabilitation. This is habilitation, I should say. And so, yeah, they have to learn how to live with it. Yeah, not easy, guys, not easy at all. The main thing is to help moms to cope with this. Okay. So like I said, I talked about folic acid already. It really does help out. Okay. Okay. And on this, the main thing is here again on the spina bifida. So I kind of went over this already. It's nursing care of spina bifida. You want to prevent infection. Imagine if that got infected. That'd be awful for the child. These kids could die because of that. You have to protect the sac at all costs. You get correct positioning to prevent pressure on the sac. You have to make sure that you're doing range of motion with these kids so that they don't get contractures. There are a lot of care. Believe me, I've taken care of spina bifida children at Texas Children's Hospital, and they really do require a lot of care, good skin care, adequate nutrition, and you just watch them. And I talked about medical supervision and rehabilitation. Okay, all righty. And mom and dads need a lot of support. Okay. Boy, I see this again. Do you think this is pretty important? Okay, so moist, sterile dressing of saline or antibiotic solution must be ordered to prevent drying of the sac. I kind of went over that again. So again, you want to make sure that, you know, you do that. If with the newborn, he's placed in an incubator because you don't want to cold stress this baby out. Well, this baby, you could probably kill the baby with cold stress. So you don't want that. So you worry about thermal regulation. And so you're going to have them in incubator and always protect from injury. Always have, whenever you deal with the sac, you always, because it's an open lesion, you always want to have a sterile environment, always. Okay, so let's do like maybe a brain teaser. So you're the nurse and you're caring for an infant born with spina bifida myelomeningeal seal. Okay, that's the worst one, right? So which intervention will the nurse implement to protect the sac?
Two.
Two, absolutely. Thank you. All right, we're almost done. Hang in there with me. Cleft lip. You have a fissure opening right in the upper portion of the lip. Okay. What happens is during the embryonic development, remember that's the first 8 weeks of life. Okay. The maxillary and the median nasal processes, they don't unite. And so what happens is that, you know, there's a failure of this to happen. So they don't unite. And again, that's the embryonic development, such an important time in the pregnancy. And many people don't even know they're pregnant during the embryonic stage. Okay. And so, you know, you see stuff like we're talking about happens. And again, I think that they're more often in boys than girls. So let me give you a picture of the cleft lip. Yeah. And the main thing I want you to remember about cleft lip is that they're open for infection. They have a hard time feeding, so they have to have a special bottle to feed. And they have to wait to have surgery. It doesn't happen right away. They have repair by 3 months of age. And you want to make sure that this baby doesn't scratch, okay, their lip. You want to make sure that when they have the chilioplasty, that baby, you know, it's going to itch. It's going to probably get itchy. And so you want to keep the baby's nails away from the lip because you want a good, you don't want a scar. You don't want a deep scar. You want the tissue to really heal properly so that you have minimal scarring. And like I said, a special syringe or bottle may be necessary to assist in the feeding. And then even afterwards, you gotta be careful. You don't have any kind of sucking. You don't want these babies to suck. Okay. So again, you're gonna feed by medicine dropper until wound is completely healed. After surgery, if you have the chilioplasty, use about 2 weeks afterwards. And you always want to cleanse the mouth by giving the infant just a small amount of sterile water at the end of each feeding session. And that's sterile water because, again, you don't want anything to get in there to be infected. All right. So the next malfunctioning is the cleft palate. Everybody knows where the palate is. It's the hard plate that fuses in your mouth, and you really need that to come together, and that usually comes together during the 7th to 12th week of gestation. Okay, so again, the 7th week is the end of the embryonic stage, because by 9 weeks you go into fetal development. So, you know, this is a really tough time. Hopefully mom's on good vitamins at the time, having good nutrition. They are at risk for respiratory tract and middle ear infection. Write that down. Write down that a child with a cleft palate is at increased risk of infection of the respiratory tract and middle ears. They get a lot of ear infection, guys, a lot of ear infections. So what's your nursing care going to be for this child post-operatively? Well, you don't want to put any food through a straw. You don't want this child to be sucking. You want to prevent sucking. Now, is that hard to do on a baby? Sure is. Okay, because that's how they get their feeling of comfort, is by sucking. So you taking that away. You must always be sure that you do clean the mouth with the water, and usually sterile water is the best. Speech, encourage children to pronounce. They can have, because the palate, the heart plate it has to be fused back together. They can have problems with pronunciation of words properly. A lot of times they go to a speech speech therapist to be able to learn how to put words together. You want to provide diversion to these children because they need to be kept a little bit more quiet, or so crying should be avoided whenever possible. Play should be the quiet type. You have a child, you don't want them outside riding a bike or playing baseball or anything like that. You want them to be quiet. And then the main thing is on the complications. Children with a open cleft palate are open to middle ear infections. And two, they also have problems with their teeth because the palate didn't fuse together. So, you're born with all the teeth you're supposed to have in your lifetime. And so they might not come through correctly. So you might have to get a pediatric dentist. All righty. All right, let's go forward here. Okay. So what condition is commonly associated with an infant with a cleft palate? What problem?
Ear infection?
Ear infection, good. Middle ear infection. Okay. All right. Let's go on here. This another area that I want you to make sure you understand and know is on hip dysplasia. Hip dysplasia. So this is a really good picture. It does show you when the hips don't line up, there could be some developmental problems in utero with hip dysplasia. And sometimes too, oops, excuse me, you can see here the folds are off here. You can see the difference. You can see this child here has, this leg is shorter, and then this one comes down a little longer. Again, it could be that the femur, and this one too, you can see it, the femur of the leg doesn't go into the acetabulum like it should. So therefore, you can hear like clicking noise. That's the Ortolani sign. And that's indicative of a hip dysplasia. Okay. So it applies to various degrees of deformities. You can have, partial or complete. And when you're looking at the child, like in the prone position, one buttocks appears higher than the other. I just showed the picture. The head of the femur could be partially or completely displaced. And then 7 times more common in girls. Woo! And then more apparent as an infant toddler, begins walking. So a lot of times, to be honest with you, in the pediatrician, when he comes in, he'll look at the baby's hips, okay? And when you take them to the office, pediatrician's office, they can usually see this a lot more. This is where the head of the femur is out of the acetabulum. And so child, when he starts walking, you could probably see it a lot more too. All right. Any questions or anything? You still with me? Okay.
Yes.
Okay, that's all I care about. All right, we're almost finished. Let's see here. So if you were like assessing a newborn and you notice the gluteal fold to be higher on one side. What are you thinking of?
Hip dysplasia.
Exactly, you got it. Okay. All righty, let's do this one here. This one, oh, another little brain teaser. The nurse is assessing an infant with a tuft of hair. There's a dimple on the sacrum. What's she concerned about?
Spina bifida.
Spina bifida, good. Okay, that's a spina bifida occulta. Yeah, okay, yeah. The hair gives you the clue that there's something not right because you shouldn't have that. All right, all right. So did I go backwards? Let's see here. I went over that already. I guess, okay. Anyway, we went over these different types of spina bifida, and it's just another slide that I put together there on it. Let's go to PKU. Okay, so this is another problem where you have faulty metabolism of what we call phenolphthalein. Okay, so phenolphthalein is an amino acid that's essential to your life. Okay, now where do you find that? Well, you find it in protein. Good, thank you. Appreciate that. And so what happens is that the infant's unable to digest this essential acid. And the phenolphthalein then goes up. It accumulates in the blood, okay? And so when he excretes it, it can be found in the urine within the first week of life. Okay. So, but we want to know before the first week of life because it's only a few days that baby takes in protein and if he can't break down this phenolphthalein and accumulates, he can get severe mental retardation. So in the United States, all infants born get a PKU test. Maybe you heard that term, PKU. That's just, it means this word right here, okay? And what we do is we do the Guthrie test. It's called the Guthrie test, Guthrie. And let me see here. And the Guthrie test is a blood test. And we do it a heel stick. And don't forget, you never stick a baby in the middle of the heel, right? You go to the side. And basically, we're looking for this. Now, let me ask you a question. If, let's see, oh, let me go here. If this is about, we're talking about protein. Do you think we could take the blood test at 1 day old? No.
No.
No, because the baby has to have at least 2 to 3 days of protein before we can do PKU. The best, let me tell you, the best is 3 days. That's why these babies get this PKU test done when they're about to go home, okay? Because we got to get enough protein in the body in order that we can see if the baby's able to break down this amino acid, okay, to break down this phenolphthalein. And so he doesn't accumulate it in his blood. So you have to have enough days of protein in order to see it. Now, we don't want to wait till a week where that's when the phenolphthalein starts to show up in the urine, because by that time, a week, it's already accumulated in the blood. Does that make sense to everybody? So,
Yep.
Okay, so you got it. So we got to get this done before it leaves the hospital. And every infant gets it done before they leave the hospital. So what you see with these babies is they appear fine at birth. You know, it's not like you can see the faultiness. It's in the metabolism, how he breaks down these amino acids. So by the time that I said urine test is positive, brain damage has already occurred. It's too late. That's why we do blood tests. And I tell you, if you've ever done a PKU test on a baby, it's a special, you have to make sure you get the blood in those little circles, Okay, it's like comes on a little pad. And it's got 5 little circles, and you have to make sure you get a drop of blood inside the circle. And if it's outside the circle, the test is no good. It's very sensitive test. Now, the child has a musty odor. You see I highlighted that? The child has a musty odor. Sometimes questions will have that, and you have to pick out which abnormality that would go to. Okay, all right. So again, I said they're found in all protein foods. I guess that slide is pretty important. All right. All right, let's move on. So if a child can't take in protein, then he has to be on special formula. And the formula that I've seen that Hesse likes this kind of question is low phenolic, as I highlighted here. The Phoenix 1. These are special formulas that are available. These it's a lifelong problem with dietary. And as these children grow, they'll have to have special nutrition guidance. Okay. Now, let's talk about maple syrup's urine disease. These children appear healthy at birth. Problems just soon develop. And what they are, excuse me, they're poor feeders. They lose their moral reflex. Remember that reflex I said, the startle reflex? When these kids lose it, they have hypotonia. That means they have very low tone to their body, very low tone to their muscles. They have irregular respirations, and these kids can seize. They can have convulsions. How you pick it up is that urine, sweat, or earwax, they have a characteristic of a maple syrup. It's a sweet odor. And what happens, that sweet odor is caused by ketoacidosis. And so you can have like fruity odor of the breath, you know, and so you want to make sure that you get these kids looked at right away. Okay, so again, write down maple syrup urine disease, write down what? Sweet odor. All right, it does, it smells like maple syrup. That's why it's called maple syrup syndrome. All righty. Galactosomia, that just means too much sugar in the blood. It can begin abruptly, worsens, I love that, gradually. Early signs you see is lethargic, vomiting, hypotonia again, low toned, diarrhea. And these babies are small. They're called failure to thrive. It begins just as the newborn is fed, and jaundice could be present. So what are you going to do for these kids? Because they can't, what happens is that milk and lactose, they have sugar in them. And so we have to take that away and eliminate it from the diet. Unfortunately, breastfeeding has to be stopped, and you go to a soy protein-based formula. So it has to be lactose free, because they can't, again, it's in the metabolism, they can't break down the extra sugar that's being secreted. All right, Down syndrome. Most common chromosome anomaly, it happens a lot we see it more with older women having children. We have the cutoff time of age 35 because that's a advanced maternal age patient. Gets more riskier as you get older to have babies. Even though we have a lot of women having babies in their 40s and 50s now, they're just high risk. So we have to be, more astute to, complications that can occur. So what we can do is offer a mom an amniocentesis in the beginning of pregnancy just to get a chromosomal analysis. And what we're looking for is the nice little pairs of chromosomes. And sometimes You could have one chromosome that decides to, you know, he doesn't want to connect with one, so he connects with the other one and make it a threesome. And that's where you come into these chromosomal anomalies. And the children can have some, it ranges from mild to severe. And what you see a lot is the creases on the palm of the hand, simian crease is called. Okay. We talked about amniocentesis. That's the most accurate test for Down syndrome, offered to advanced maternal age mom. You can also have an alpha-fetoprotein test, and that can be done around 15 weeks of gestation. But you see it, I'm gonna be honest with you, you do see a lot of false positives with that. So you wouldn't want to base a termination of pregnancy, if you wanted to, based on alpha-fetoprotein test results. You would want to go a little further and do the amniocentesis. Then you can make your decision as to what's good for you and your family. Okay, but again, amniocentesis is the most accurate. So here's your manifestations. You see, here's your simian crease. You see just that. It's a crease that goes straight across the palm of the hand. These babies have a protruding tongue. They have low set ears, here, and you can see their eyes. Okay. So there's the chromosomes just didn't line up like they're supposed to. What happens is that they can be a limp, flaccid posture. What happens with these children, again, like the other two, like with maple syrup and glycemia, they have hypotonicity, low tone of their muscles. So it's difficult to position, it's difficult to hold. They can have heat loss, so thermoregulation would be a problem with the newborn. They could have respiratory problems at birth, which causes them to have respiratory illnesses because constipation, because again, you have low tone to your muscles. Okay. And then acute leukemia has been pretty high with these children. And then the research has shown where these kids, when they grow up or reach middle adulthood, now they're prone to Alzheimer's. And that's an interesting area to research more into. And then you always have to give support to any of these children. Parents need a lot of support, their feelings, concerns, and provide them with support and community referrals. I've had, instances where it was undiagnosed Down syndrome. It was years ago before they had all these great tests. And I had a mother that didn't even want to look at her baby. She didn't hold the baby. The father didn't hold the baby. And then they left the baby at the hospital that we had to find a foster care. Yeah, it's sad. Yeah, it's real sad. Another problem is with erythroplastosis fetalis. That falls under the blood diseases of the newborn. So becomes apparent in utero or soon after birth. You have an Rh negative mother and you have an Rh positive daddy, and they produce an Rh positive fetus. Well, if mom's negative and baby's positive, remember, negative and positives, they never get along. Okay, so mom's problem is that we don't want to mix, but sometimes the bloods do mix. So a small amount of leaks can allow the fetal blood to enter the maternal circulation, causing the mother to start producing what we call antibodies. Think of these men, little construction men, with little tools, and they call antibodies. Now they're going to cross the placenta and destroy these beautiful blood cells of the fetus, of the erythrocytes, beautiful red blood cells. So these little guys, they got their little hammers and everything, and they're going to cut down the red blood cells of the fetus. Well, that causes the baby to have anemia because he needs red blood cells, right? And remember, red blood cells carry oxygen. So now you've got this growing fetus that could have heart failure and will not grow properly in utero. Okay, so it is a problem, but we can take care of that problem. Okay, so here we're just showing you the little picture, and you can see here where, here is the red blood cells of mommy, and it's negative, okay? And here's little baby. Now his little cells are positive. And even though we don't want these two to mix their blood, sometimes you use a little bit of a leak, okay? And so what happens is that mommy starts making all these anti-Rh antibodies, okay? And then they go in and they just chop, 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 chop all these beautiful red blood cells of the baby. And that causes the baby to be anemic. Now, when we know that's happening, sometimes they can do an intrauterine transfusion, but that's only if necessary. And I can tell you, I have about 45 years of labor and delivery. I've only seen it once. So what can we do? We give mom RhoGAM, everybody. So RhoGAM, RHD immune globulin. And I tell you, they're both the same. RhoGAM, this is what RhoGAM is. It's another term. We shorten it to RhoGAM, but it's RHD immune globulin. And I tell you, who likes to use this term? It's HESI, the HESI exam. So you might see that on HESI. And you administer this to a baby, to mommy, 72 hours after delivery. Okay, so it has to be administered within 72 hours after delivery with an infant who is Rh positive, or if mom has any kind, truthfully, if mom is Rh negative, she has, so delivery, they get RhoGAM. After an ectopic, they're going to give RhoGAM. If they have an abortion, they're going to get RhoGAM. And what you're always doing is you're always protecting the next pregnancy. And then also mom gets it during pregnancy, so that you already have this on board to protect this pregnancy. Okay, that's always a good question. Okay, all right, we kind of already talked about this glycosemia. Anyway, I already went over that. It's just the enzyme needed to help the liver convert glucose to glucose. I think I just went over that. Okay, but you can see it, and the main thing is early diagnosis is supported. I think my slide got out of whack here. Okay. All right. I think my slides were got something went different. Anyway, I already went over Maple urine disease treatment and nursing care. The main thing is hydration and peritoneal dialysis to decrease serum levels. Okay. If you got maple syrup. Sorry about that. That kind of got out of whack, and it's not supposed to be down here, but I'm just going to go over a little bit with you. It's a lifelong, I think I told you this, lifelong diet low in amino acids. You have to be very careful of the diet again. So she's going to have a nutrition consult. All right. All right. Again, with these kids, infection can be threatening. All right. Let's go here. We kind of went over phototherapy, and we did this. Okay, we're just going to go down here. Let's go to this one. All right. So neonatal absence syndrome. Okay, so know this. Neonatal absence syndrome is.
Professor, what happened to the PowerPoint?
Yeah, I think I had a duplication my PowerPoint here, and it kind of got out of whack. So we've already gone over all this. Sometimes when you duplicate things, it kind of get out of wacky. But anyway, so we went over all that already. And so now I want to go over this with you, because I know you're probably getting tired. Because you'll probably see this again. All right, you got that? And so neonatal absence syndrome is caused by fetal exposure to drugs in utero. Okay, so in other words, mom takes in a drug during her pregnancy. It crosses the placenta. It's called transplacental. Crosses the placenta. It goes right to the fetus. Okay, now don't forget, this baby is getting this drug quite often during pregnancy if mom's a drug user. Okay, so now mom is going to deliver. So now baby no longer gets the drugs. The baby goes through the same withdrawal as the adult goes through withdrawals, okay, it's terrible. Is they get, because they're addicted to the drug the mom was taking. So now they don't have that anymore. So what happens is they have terrible withdrawals, like I said, and they have long-term development and neurological problems. And so these babies need a lot of care. So what you can see is body tremors and hyperirritability. That's the primary signs. Hyperirritability and body tremors. Now, these kids cannot go to sleep, so they're awake. They're awake. They have diarrhea. They're a poor feeder. Okay, poor feeders, and sneezing and yawning can be seen on these kids. Now, Hesse likes these, put these in, sneezing and yawning. Okay. Now, how are you going to do the, what's your testing going to be? Well, through the feces, through meconium, can be more accurate than neonatal urine testing. It's more accurate. You get to see more of the drug there. Now, what's your treatment? Well, you're going to wrap the baby up in a nice swaddling effect. You want to decrease stimulation. So you're going to have this kid in a quiet environment. Because remember I said he can't sleep. He's always awake. So he's got wakefulness. So you want to give him a quiet environment so that you can promote going to sleep. These babies can have seizures. And so what you want to do is that you could probably give them some phenobarbital and help with the seizures. Yes, these babies are pretty sad. And a good question on a test could be, guys, could be, what are the symptoms? What would you see? And you would have to know these. And so be careful when you're reading these questions. So again, how does a nurse take care of an infant who's withdrawn from an opiate? See how this baby is all swaddled up? He's wrapped up really, really well. And that gives him a sense of what? Safety, comfort. These babies, you try to, they're crying all the time, and you want to, we want to rock babies back and forth, but just that rocking motion will make them more irritable. So a lot of these times you just swaddle here. See here, just swaddle this baby up, wrap them up real tight. They look like this, and then just let them be, because they have to get that drug out of their system. Now, is that hard to do? It is tough. It's tough. There's no doubt about it. So that's a baby born addicted because of mom. Okay, it's called neonatal abstinence syndrome. You'll probably see that again. Okay, so let's go on now and almost finish up with a couple more slides. Hang in there with me. Infant of a diabetic mom. All right, so because mom's diabetic, there's a large amount of glucose that's actually transferred to the fetus. Okay, glucose can cross the placenta, and the baby becomes, hyperglycemic in utero. So he's got too much of sugar. And his little pancreas, remember, it's just, it's tiny, is trying to keep up with the hyper sugar level by trying to produce more insulin. And so that can lead then to too much insulin, hyperinsulinemia. And so when you have that, and when you have too much protein and fatty acids, what do you get? You get a large for gestational age infant. So you can write that down. When you have pancreas leads too much insulin, leads to along with too much insulin, along with excess production of protein and fatty acids equals LGA, a large gestational age baby, weighing 9 pounds or more, which is classified as a macrosomic baby. A macrosomic baby is a baby that weighs 9 pounds or greater. Big babies can have big problems. Okay, now the biggest problem after they deliver can be from hypoglycemia. Remember, during 9 months in utero, they're getting fed all these great Snicker bars, say, okay? Every day, all day long. That's good, right? All right, now we're born. We've been cut off from all our Snicker bars. There's no more Snicker bars, okay? So now my blood sugar is going to, it was up here, it was high, and now is gonna drop really low. So we're gonna get hypoglycemia. Not a good thing. Because what happens is that babies go from hypoglycemia, they can also have problems with breathing. They can go into respiratory distress syndrome. So you want to make sure that you're on top of things. You want to get that blood sugar level, because if it's real low, baby needs to go right to NICU to get IV glucose. Okay, another problem these kids can have is low calcium. So calcemia can happen. And then they can have hyperbilirubinemia, which means too much bilirubin circulating in their system. Therefore, they will get jaundice. So it's not a good thing. So you have to be really careful with these infants and diabetic mothers. They usually go to the NICU for 24 hours at least for observation. Now, when they're born, sometimes they have this cushingoid appearance, or they look real healthy, but the cushingoid appearance is like a moon face. Okay. So this is what my macrosomic baby looks like. You can see that they have a big face. You can see it's swollen, like a little moon face here. You can see they're big babies. And this baby is in the NICU. He's being monitored very closely. So you watch him for low blood sugar. He has here an IV, which is probably getting some glucose through. And we got a gavage feeding going on. These babies can be very sick. And so they have to be very careful as to for respiratory distress. Okay, so what are you going to monitor? Well, obviously glucose levels. We're going to watch the vital signs, watch for signs of irritability, tremors, and as I said, respiratory distress. So glucose levels that go really low, this 40 milligrams per deciliter is really low, can result in rapid and permanent brain damage. So that's why I say a lot of books use 45 milligrams per deciliter hypoglycemia. And when you get down close to 40 and below, then you can have brain damage. Never good. Never, no. So you gotta watch these babies very careful. Okay, let's see here. All righty. So here we go. This is an LGA baby, large gestational age, kind of cute little baby though. And what condition of the mom is a contributing factor? Diabetes. All righty. Let's go on here. We're gonna go on to meconium aspiration syndrome. Meconium aspiration syndrome. Your symptoms. These are kids that again have aspirated. Now, remember I talked about the suctioning before? Okay. So this now, because they took their first breath before you suction them out altogether, now they have this problem. They're going to have respiratory distress because they aspirated on the meconium and now it's in their lungs. So they're going to have respiratory distress. That thick tarry substance is going to cause damage to their lining of their lungs. They will have nasal flaring because they're trying to breathe. They have retractions sternal chest retractions, because they're working hard to breathe, they can't breathe. They're gonna look blue to you, because they're not getting enough oxygen. Grunting, they make these grunting sounds, and when you have all retractions, nasal flaring and grunting, you're gonna have rales and rhonchi. Their lungs are they've been damaged to a certain point, okay? Because of the meconium they took in, they aspirated on their own meconium. And of course, tachypnea could persist for several weeks. These kids are sick. These kids are real sick. Now, how are you going to treat them? Warmth. Keep them warm. Don't cold stress these kids out. No way. Thermoregulations, number one. Oxygen. You're going to give them oxygen, supportive care, and they'll be in the NICU. Oh, absolutely. They'll be in the NICU. Okay. I'm just kind of giving these out. What is active cyanosis? We went over that. Remember, hands are blue, and so are the feeties are blue. Okay. All right. Let's go on here. Let's talk about the head a little bit. Molding can happen because of delivering. You know, sometimes when these kids are low in mom's pelvis, their heads will, what we do is conform to the shape of mom's pelvis. So you can have some swelling. Now, I want you to write this down. Caput succedaneum. Remember, that's where you have swelling of the soft tissue of the scalp, and it crosses the suture line. So you have the suture line going down the middle of the head, and because this caput succedaneum is like on the crown of the head, it's swollen. There's fluid. That's fluid, guys. So that's fluid underneath the scalp. Okay, so it does look, you know, it's puffy, but it goes down. But this one does cross the suture line because it's right there over the sutures. Okay. Now the other problem that you can have with a tough delivery is cephalhematoma. And now the cephalhematoma is a collection of blood under the scalp. It's on the side of the head. So take your hand and put it on the side of your head, okay? And hit your head. Go boop, 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 boop. Okay, that's a cephalhematoma. Now, that will go down, okay? And it does not cross the suture line. Does not cross. So if you put your hand over the side of your head, and you see a cephalhematoma, you know that it can't, because the suture line is up here. So you know it can't cross the suture line, okay? All right. So that's kind of good if you do that so that you feel it, okay? Now the cephalhematoma, because it's blood, the blood will be reabsorbed into the baby's body, okay? Now the only problem you have after delivery with a cephalhematoma is that because the blood is reabsorbed into the body, it's going to put more pressure on the baby's liver to break down that excess amount of what? Bilirubin, okay, red blood cells. So with extra bilirubin going through the body, you can get more jaundice. So that's what happens. That could be the result of a cephalhematoma. Okay, and we already talked about the fontanelles, and we said about soft spot. Okay, all right. And I just put this in here because I always like the scalp to show you, you know, the frontal bone. Here's your frontal fontanelle I talked about. And then down here, you'll see the posterior fontanelle. And then you have all these different landmarks. So here's the suture line I talked about. Here's another, this is a better picture. Anterior fontanelle, frontal lobe here. Okay. So you got, oh, here, this is the frontal. I'm sorry, this is the frontal. It looks more like a what, diamond shape, and it's bigger. The frontal fontanelle is bigger, and then here's your posterior. Sorry, that was backwards. All right. So again, recapping, bulging fontanelle is not good. It could be result of the condition of hydrocephalus, too much cerebral spinal fluid in this fontanelle. A sunken fontanelle is a result of dehydration. Okay, all right, hang in there with me. Again, this is just, when you go back over looking at things, it's just good to fill in the blank. What is molding? What is capsulectomia and what's supple hematoma? And it's always good to write things down. All right. And no, on the test, there is mathematics. And let me just say something. If it says to round to the nearest 10th, do it. I've seen where it says there is bold, it says nearest 10th, and people leave it as in the 100th. So don't read it carefully as to if it's to the 10th, do it to the 10th. If it says round to the whole number, round it to the whole number. Don't put, just put the number in there. Don't put milligrams or milliliters or anything. Don't label it. Just put the number in your answer. Okay. And then, you know, you got your calculation, desired, what you need, what you're supposed to have, what you have on hand, and don't forget your quantity. Okay. And I put this in here too. Again, it's just a recapping. Round to the nearest 10th. That's what you do. Round to the nearest 10th. Okay. All right. Just read it carefully. And you all did really good on your intake calculation, intake and output. There'll be a question on that too. So again, you want to make sure that you brush up on that if you're not sure, but you're doing really good with your math. Okay, I think, how many people are still with me? Okay. So Brandy, oh, hi everybody. Good, I'm glad you all joined me. Hi. So let me stop sharing the
ma'am.
screen. Right here, hold on here. Let's see. My back. Where is everybody? Oh, here, let me go here.
Yeah.
Lost you all. Okay, here I am. Here's everybody. So anyway, that was really a very comprehensive exam 3. Let me recap, make sure that you all have this down. We went over,
Excuse me, are you recapping from chapter 10?
no, the last chapter, chapter 14. I already did chapter 10. Winnie, I already did chapter 10 recapping. And now I'm on to the last chapter, chapter 14. So let me recap what we just went over. Are you ready?
Yeah.
Okay, so cleft palate, we went over. We went over, remember cleft palate? What's the problem with cleft palate? It's with middle ear infection, right?
Yeah.
Okay, good. Okay, good. We went over gavage feedings, the nursery responsibility for what? Aspirating the gastric contents before giving the next feeding, right? Okay. We went over phototherapy, where you're gonna have the baby under the Billy lights, right? To break down the SS bilirubin. Okay. We went over hip dysplasia. How do you recognize it? Abnormal glucose on the buttocks folds, right? We went over hydrocephalus. Too much fluid in the brain, right? The head. So the baby has a really large head and must be supported during feedings. Okay, so again, it's a open neural tube defect. Okay, we went over spina bifida, keeping, especially with the meningeal seal and the meningeal myelocele, is that you have a sac and you want to protect the sac at all costs. You want to protect it from infection, and you want from drying out. You want to put maybe a moist, sterile saline towel around the sac. Okay, all right, we went over that. Neonatal absence syndrome, we went over that. They need what? They need swallowing, they're irritable, they're always awake, so you want to have an acquired environment. Okay, all righty. We went over Down syndrome. Okay, let me see. We went over maple syrup defect, they have a sweet smelling what? Aroma to their urine. That's how you pick it up. Okay. We went over depressed fontanelles. That's dehydration. Post-term after 42 weeks. Bulb suctioning. I went over bulb suctioning, right? You don't ever put the bulb suction in right straight in because you can elicitate the gag reflex. So put it on in the side of the mouth, right? You want to prevent the stimulation of the gag reflex. All right. We went over caput succedaneum. It does cross a suture line. It does go away. Cone-shaped heads do resolve themselves. Just takes a little couple days. The cephalohematoma is on the side of the head. That's where too much blood is there under the scalp. It's on the side. It does not cross the suture line. All righty. All right. Let's see. We went over LGA babies, large for gestational age. And that's usually the mother has what? Gestational diabetes, right? Okay. We went over hemorrhage. Okay. Look over a little bit about episiotomy, the different degrees 1, 2, and 3, and 4. Now, if a baby is, say, 43 weeks gestation, and the baby has a low APGAR score, so now the baby's going to go to NICU, what would be one of the first things that a nurse would have to make sure she has set up in the NICU? So what she wants to make sure that you're set up in the NICU is make sure that, well, the oxygen tubing is there. You have oxygen ready for this baby because this baby is going to need oxygen. If you got a low APGAR score, say, my gosh, 1 and 4, like 1 at 1 minute and 4 at 5 minutes, you got a sick baby. That baby's going to need oxygen. It's going to need a warm environment. So make sure you have your oxygen and everything set up before, the baby's taken to the NICU. Okay. All righty. Let's see. We went over respiratory distress syndrome. And we went over bilirubin level. And we always want to make sure that mommy is what? Yeah, continue to breastfeed every 2 to 4 hours when you have a high bilirubin. Okay. All right, the only thing I see that I didn't go over too much was circumcision. So look over a circumcision, normal care, cleaning the circumcision area, make sure that it's not red and doesn't have a whole bunch of drainage. Okay. All right, everybody. It was really nice for you all to be with me today. And I hope that this will help you. And do me a favor.
Thank you.
You're welcome. Do me a favor on the test. You want to read the questions carefully and ask yourself, what is this question asking me? Because a lot of times by now, you may know a lot. You have a lot in your head now. You know what I mean? And so you may be saying, oh, that's that. But make sure that you're answering what the question is asking you. So that's why I always tell my students to read the question carefully and ask yourself, what's the question asking me? Okay? All righty. Well, that ends today. So I wanted to wish you a nice weekend. Keep studying.
Bye.
Thank
You're
you.
welcome. You're welcome. And keep studying. Keep, all these things I just went over right now. You got it.
Thank you.